So let's discuss the short arm cast that you're going to apply. What are the steps?
Well, first, I need to examine the area and check the x-rays to see if surgery is needed. For the cast, first I'll apply a stockinette with a hole for the thumb, and then I'll wrap the arm in a web drill for padding. After that, I need to immerse the roll of plaster in water.
Right. And what should you point out about the plaster?
I need to warn the patient that it may feel hot as it starts to set. How long does it take to dry?
The cast may feel dry to the touch in a few minutes, but it isn't fully dry for 72 hours. What's the last step?
After I've applied the cast, I need to take another x-ray to confirm that the fracture has been reduced.
You hear a manager explaining new data management processes to clinical staff.
Yes, in the back. You had a question?
Yes. How should we file our feedback reports? Do we need to just complete them on the computer?
That's a great question. Remember that since the clinic has begun transitioning to the new computers and software systems, we need you to fill out the paper reports in addition to the digital versions. I know this may be time consuming, but this is because as we transfer all our files from the old servers to the new ones, some files may be misplaced, and we want to ensure that all of our records are easily accessible at all times.
So we need to make 2 copies of our reports?
Yes, exactly. Great. Does anyone else have a question?
You hear a presentation about the introduction of a new type of wound dressing.
Thank you all for coming. Well, after some research, the hospital has decided to invest in a new type of dressing to care for our patients with chronic wounds, such as those with diabetic ulcers. Although the traditional cloth compression bandages are useful, they need to be changed frequently to promote healing. These new bandages are made of a natural plant-based material instead. In fact, they're made from seaweed. Alginate dressings are somewhat costly, but they can prevent harmful strains of bacteria from entering the wound by forming a protective barrier with the skin. Most impressive of all, they can absorb up to 20 times their own weight, so they're the best choice for wounds with high-level exudate. Based on these factors, we believe that alginate dressing would be a useful addition to our wound care procedures.
You hear 2 hospital managers discussing completion rates for an online course.
It looks like only around 40% of the staff have completed the online health and safety course so far.
Less than half, but the course has to be completed by all staff members by the end of the month. Can we send them a reminder email?
We've reminded them by email twice already. I've even phoned a few people. I think we need to bring it up at the general staff meeting next week.
That's on Thursday afternoon, right? Will that work with everyone's schedules?
It should. All staff members have that time already blocked out. But if anyone can't come, then we can speak to them in person one-on-one.
You hear 2 colleagues discussing an online training course.
Hi Fiona, how are you? Can I ask you something?
Sure, Mug. What's up?
Have you done that online training for a new record management process?
Yeah, I did it on the weekend. It was supposed to take 10 minutes, but it took me ages.
Did you have any trouble with it? I mean, any technical problems?
Not really. I couldn't log in for a bit, but that was just me getting my password wrong. After that, it worked fine. Why?
I keep getting this email that says I haven't finished all the activities, and then when I log in, it says I've completed everything. It's driving me crazy.
Did you ring the IT help guys?
Yeah, they reset it, but it didn't do anything. I really don't want to do it again.
No, you shouldn't have to. Maybe just send the register an email and let her know that you've done it. Maybe she can fix the issue.
You hear an educator describing methods for creating medical abbreviations to nursing trainees. A technical name for the use of first letters is initialing, but I prefer to use the phrase the first letter rule for this method. Abbreviations using the first letter rule commonly identify diseases and diagnostic tests. For example, chronic obstructive pulmonary disease is COPD, or liver function tests are LFTs. In most cases, these letters are pronounced separately as letters, but sometimes key letters or key syllables form the abbreviation. For example, hypertension is abbreviated using HTN, or we see the term atrial fibrillation abbreviated as either AF or AFib. Sometimes the first letters form an easily pronounceable word, an acronym. For example, acquired immune deficiency syndrome becomes AIDS, or severe acute respiratory syndrome becomes SARS. Understanding these principles will help you to more quickly learn the many abbreviations used in local clinical settings. You hear an interview with a health administrator called Dr. Marvin Lee, discussing an article about delivering high-quality non-visit care.
No. Sorry? Can you start page number 100? Okay, this is for reading. Listening. Okay, just one minute. open the file. Yes, part C, extract 1, right? How does Julie describe? Okay, okay. Hmm. Okay.
আদাব ভাইয়া আমি আসলে ভাইয়া ফোন চেক করি না আমি হচ্ছে আপনি হয়তো কল দিবেন হঠাৎ ফোন দিয়ে দেখি আপনি লিংক পাঠিয়ে রেখে দিচ্ছেন আর দেখি নাই কোনটা করতেছেন ভাইয়া রিডিং না লিসেনিং ওকে
No. Yes. No.
Non-visit care. You hear an interview with a health administrator called Dr. Marvin Lee discussing an article about delivering high-quality non-visit care.
patients are increasingly seeking to have their healthcare needs met without coming into an office. And there's a strong possibility that non-visit care will become the rule rather than the exception. I'm Jan Dean, and my guest today is Dr. Marvin Lee, co-author of a recent perspective article about strategies for delivering high-quality non-visit care. So, Dr. Lee, what do you think that the transition to non-visit care systems will look like?
Well, I actually think you'll see a variety of responses. Existing medical institutions will pilot and are piloting these programs and gradually scaling them up. And at the same time, of course, new organisations are entering the market and changing practices, changing how things are done. So I think it'll be a mix of both of these. And really, my sense of this is that it first has to start with culture, developing a culture for non-face-to-face medical care.
Oh, I see. Could you say just a bit more about what you mean by culture here?
So what I mean is, if you create a culture in an existing medical organisation where an in-person visit is viewed as what you do after you have tried, in a very safe and highly effective way, to meet a patient's need remotely, I think this will change the game for how generally your organisation will think about the practice of medicine. I do think that we'll see some existing organisations differentiate and make that leap over, yet some new organisations will perhaps be at the advantage of being able to start from scratch. So I think we'll see a blend of these two responses.
I see. So, you say in the article that the goal of a non-visit based healthcare system would be to bring as much of the care and social support as possible into the patient's home. Does the technology exist to do that today?
I think in many instances, yes, and the technology is really getting better. I think it's important to reflect on how things like smartphones, particularly in the last decade or so, have influenced our expectations. There's been a massive shift in how people's everyday life think about this, and about how they expect to engage with services. So we really have to find a way to map onto that consumer demand. And I think for a lot of the basic medical needs that people have, the tech is there already.
So, what kinds of things do you mean?
Well, if you look at clinical protocols for primary care, these are designed to help physicians and clients make decisions about appropriate healthcare for specific circumstances. I think you can quite likely do a lot of that very safely digitally before you even consider meeting face to face.
But what about the times when a patient really has to be there in person?
Well, of course there are still those moments, but I think it's more about when that necessity arises. Is it earlier in the process of care or later? And what impact does it have on the patient involved? I think there are smart ways, when you do need in-person visits and interactions, to structure those so they have the least burden on the patient as possible.
Could you give an example of what you mean?
Well, one example we mentioned in the article is a scenario when a person has to provide a blood specimen or urine. They currently do need to be in person, but instead of building up an incredibly expensive office and lab infrastructure around a city, you could build up a very small collection of sensors that would be cheap to operate. The patient could simply drop the specimen at the collection point nearest them for it to be forwarded to a lab, minimal fuss, and wait for the data you need. So you can accommodate these face-to-face moments efficiently.
Finally, how can organizations go about trying to transition towards models that deliver high-quality, non-visit medical care?
In time, as the technology and science gets better, gets more precise, organizations should just look at these situations that require in-person attendance by the patient and evaluate them, and evaluate that requirement against the currently available technology to see if it's something that could be safely transitioned to an online remote system. I think it's important to really critically evaluate every moment that someone has come in. And I think that if you do that, you'll start to see clear opportunities to reconfigure your care pathways quite dramatically.
You hear an interview with a public health researcher called Dr. Pauline Davidson, discussing research on a secret safe injection facility in the United States.
Okay, my guest today is Pauline Davidson of the University of California. Dr. Davidson is here to discuss the findings of 2 studies that focused on the effects of a secret safe injection facility in the US. Dr. Davidson, thanks so much for agreeing to talk with me today. So, what was your big takeaway from your research?
One of the things people have said about opening safe injection facilities in the United States is that the US situation is fundamentally different from that of other countries where it's being used successfully. It's an argument that just because it can work in Europe or Australia or Canada doesn't mean that it'll work here. The big takeaway from this research and all the data we have so far is that these kinds of facilities have a similar effect here in the United States as they do elsewhere. They reduce harms associated with drug use, and they reduce social nuisance associated with drug use in the same way they do elsewhere. Basically, anywhere that you have a concentrated street-based drug scene involving a lot of fairly impoverished people using drugs, you get the same set of problems, and the people using drugs have the same set of problems. And these facilities deal with them quite well, whether they're in Vancouver or in Los Angeles and Skid Row, or any other area with a lot of drug use anywhere.
So, how did staff get this secret facility going?
This is an organization that was providing other services to drug users. They were in this really frustrating situation where they had a lot of people they provided services to who were dying of overdoses. After looking at safe injection rooms and how those work elsewhere in the world, they realized that if they waited for advocacy to legalize these facilities in the United States, all their people would be dead. So, after a good deal of discussion about it, they decided to implement something along these lines. Initially, they started by re-equipping their bathroom, so it was better suited to safe drug consumption. But that had too many logistical problems. They couldn't use the toilets because drug users were in there. They had a spare room available, so they refitted that. They modeled it after the Vancouver facility and opened their doors to a group of their longer-term users, and continued ever since.
What actually happens? How do they ensure safety and that kind of thing?
Well, it looks pretty much like an ordinary clinic. It's a fairly large room with 5 separate stainless steel injecting stations, and the staff are always in the same room as the clients. People come in, do a check-in on a laptop, sit at an injecting station, and prepare and then use their drugs. Then there's a couch if they want to sit there and wait for the immediate effects of the drug to wear off. The staff are trained to use naloxone and, if necessary, call 911. And since they're in the same room, they observe people injecting, and if they see some injecting practices that are less than ideal from a public health point of view, there's an opportunity to talk about that. So there's a number of benefits to having a staff member in the same room, rather than just overdose prevention.
What do users like about the facility?
Well, the biggest one that they kept talking about is how they're able to get out of the public eye, take their time, and use in a clean, well-lit space. People talked about using in the public eye and shooting up in a hurry between 2 cabs in the streets. They were very much aware of passers-by, not just because it's illegal, they're aware of the police, but because they're aware that it's not seen as a nice thing. They're particularly terrified of being seen by someone's children, so being able to get out of the public eye was very much a relief. So there's a serious benefit to their well-being, how they feel about themselves.
Did users have any complaints about the facility?
Mostly that it wasn't open 24/7. They really liked the space, and they would like it to be open far more often. A couple of them also talked about the problem of how the organization couldn't closely coordinate or do referrals to other agencies because they were trying to keep this all in the down low. Users were quite aware of this. They were saying it would be better if this organization was really closely coupled with a treatment agency, and that handoff could be much better. The staff were also quite bothered by the fact that they had to keep the facility to a fairly small number of people and felt like they had to exclude people with mental health issues because they felt like including them would be more likely to lead to disclosure to third parties. So the organization couldn't serve a number of people who were likely at a higher need.
Yeah.
Yes, we can see the answer. I made 6. 1, 2, 3, 4, 5, 6.
Five. Mm-mm. Yes.
Okay.
Mm-hmm.
You will hear part of a consultation between a GP and a patient called Mrs. Brownstone. For questions 1 to 12, complete the notes with a word or short phrase.
Mm-hmm.
Yes.
Hi, Mrs. Brownstone. How can I help you today?
Hi there, Dr. Rivers. I'd just like you to do a test on my waters. I've had a few problems recently. I have to go quite a lot more, and it's started to burn a little and just been a little bit uncomfortable.
I see. How long have you had these symptoms for?
Well, it's been sort of goes on and off for about 3 weeks, closer to a month really. Some days it's better than others. I don't take too much notice. I put a lot of it down to age, but I don't think there's anything really serious, but just wondered. It seems a bit strong at the moment.
And have you had this sort of problem before a lot or not?
Oh yes, it's happened quite often over the time. Normally just antibiotics clear it up. I'd say I've been treated for this, at least 5 times in the last 10 years.
And you've left it for a few weeks before coming in to see me. Do you sometimes get symptoms that come and go like this?
Yes, they do. And I just try to drink more, which I'm very bad at, drinking water and such like, but I try. And it usually goes. Well, it usually just goes off by itself, really.
Okay, and what about nighttime? How are you at night?
Oh, I'm up and down a lot. 3 times out in the night at least, every night. And it's more painful at nighttime, funnily enough. And it's much more urgent. At night there seems to be a lot of pressure. I think it's been going on for such a long time it's becoming normal.
Right, okay, well, that's not something we want you to be getting used to. Let's see what we can do. When you've had these symptoms in the past, you've had the antibiotics, did it calm it down?
Yes, antibiotics seem to do the trick.
And what about accidents? Any accidents with the waterworks?
No, I just have to make sure I get there quickly. I do find when I've been sitting for a while, once I get up, I've got to go immediately. So I always want to know where the loo is wherever I am.
But if you cough, sneeze, or laugh?
No, nothing like that.
Yeah. So what I'm keen to do actually is just to give you a short course of antibiotics and see how you get on. If you've had this similar things in the past and antibiotics have helped, I think that the first step is to see what happens if we do the same thing.
Right. I'm not sure if this is important or not, but I had a series of water problems way back, 25 years ago or so. I had a colposuspension in 1980 something. I was 50. And that worked. It worked well, I think.
Good. Okay, let's keep that in mind, but we will start with some treatment. But if it's not improving, we'll need to reassess the bladder function a bit more closely.
Right, okay.
Are you allergic to any medications as far as you know?
Yes, there's a few. Septrin, amoxil, and... Oh, what's the other one? If you can just hold 2 seconds, I'll tell you. Keep it written down so that I can... So, Septrin, amoxil, and trimethoprim.
Trimethoprim. Glad I knew that, because that would have been my first choice. You've had something called nitrofurantoin?
Yes, I've been okay with that one. The nitrofurantoin, I've had it before for 5 days.
Right, thank you. So, as you asked for, I will get you to provide us with a sample we can send to the lab. I think that what I want you to do is drop back in and see us in 5 days, and we can review the results and discuss how the medicine is working, okay? You will hear part of a consultation between a doctor and a patient called Mrs. Chambers. For questions 1 to 12, complete the notes with a word or short phrase.
Hello, Mrs. Chambers. I'm Dr. Bakari, one of the obstetricians working here at the hospital. I've just come to ask you a few questions. What is the reason you came into hospital today?
Oh, well, I started bleeding.
Oh, I see. When did you start bleeding?
I had a bleed on last Sunday.
Okay, and how many weeks pregnant are you at the moment?
I'm 36 today, and I started bleeding about a week ago.
And did you have any bleeding before that?
Actually, yeah, I did, in February.
Okay, in February. How much bleeding did you have? Was it quite a bit or just spotting?
About half a cup full, and I was 28 weeks then. But the bleeding only lasted for not long, a couple of hours, then it stopped.
Okay, and when it started last Sunday, how long did it last then?
It lasted for about 3 hours, but then I'm spotting and having some old blood coming out now. Yeah, and it was quite a bit of blood. I would say about a cup full.
A cup, okay. And with this episode, did you have any pain anywhere at all?
I just get a tightness in my tummy and I get cramps. And a quite severe pain in the lower abdomen, here, for a bit. But it comes and goes. It started when the bleeding, at the same time as I was bleeding.
Okay, and did you have pain at 28 weeks when you had the bleeding then as well?
Yeah, it's just like period pains, cramping.
Okay, alright. Any other symptoms at all?
No, not really.
Okay. And with this pregnancy, other than the bleeding, have you had any other problems?
No.
Okay. And have you had a scan since this bleeding started?
Yes, I had one when I was 34 weeks. And they found the placenta was low, but I haven't had another one since.
Okay, and when is your next scan due?
I haven't got another one now.
Okay. Alright, and when you had your booking scan at 12 weeks, everything was normal then?
Well, in my first scan, they struggled at 12 weeks to find it, so that was sort of like an internal scan, but they just said it was because it was a small baby or something. But other than that, everything was normal, I think. My visit at the antenatal clinic, everything was normal. I remember my Downs risk was low.
Okay, so everything was fine. That's good to hear. Alright, have you had any previous pregnancies?
Yeah, I've got 2 little boys. They're 2 now. Both very healthy, just a bit naughty.
Alright, they twins?
Oh yes, sorry, they're twins.
And was it a normal delivery or was it by cesarean section?
No, normal.
Normal delivery, no instruments used, nothing like that? And you didn't have to go into the intensive care unit or neonatal unit, nothing like that?
No.
Okay, alright. I think
migraines, body aches, and even a fever with my period. One time the pain got so bad I had to go in for an MRI, and they found some pretty big fibroids, and at the time we were struggling to get pregnant, so the doctor suggested I have the fibroids removed. I was really nervous and considered not getting it done, but it seemed to work really well. And 2 years later, we had our boys. I never really felt any ill effects from the procedure, apart from just taking time to heal.
You hear a doctor and a nurse reviewing a coma patient.
Okay, this patient has been out for some time now. We had quite difficult intracranial pressure control yesterday. We decided not to rock the boat, and you can see as a result he had a low intracranial pressure all day. His circulation has stayed quite stable, blood pressure's good, heart rate's low. What are his pupils doing?
They're quite small.
So they're smallish, but not tiny. Is he showing any reflexive responses?
No.
Has he got a doll's eye? Let's have a look. Okay, is he coughing when you suction?
No, he isn't.
Not coughing? Okay, this indicates that at best, his recovery will probably be incomplete. The worst option is that he will remain in a coma with little responsiveness.
You hear a consultant emergency doctor talking to a patient following an accident.
Hello, Ellen.
Hi, Doc.
Can I just take a minute to talk to you about the injuries we found?
Sure.
So firstly, your neck looks fine. So in a minute, I'm going to get this brace off and you'll be able to move your neck. But you've got a fracture of your shoulder blade, a fracture of your thigh bone, a fracture through the tibia and fibula, the lower leg bones, and there are also fractures in your ankle, the talus, your heel bone, and the ankle joint above it, the calcaneus. We were quite worried about the blood flow past the fracture in your thigh, so we did an angiogram and a CT scan, and they actually show good blood flow. So with these injuries, you're going to need surgery, and it could be a bit complicated.
You hear a clinical researcher introducing a professional development workshop. Welcome to this workshop, Understanding Clinical Research Statistics. My name is Ivan Saxon, and I'm going to lead the workshop today. I'm the head of the Acute Care Surgery Unit. It's an academic unit in the Department of Surgery. This course is not the mathematics of statistics, though. I believe that a first contact with medical statistics should lead you to an intuitive understanding of the ideas behind the numbers. It should leave you with a deep sense of understanding what is meant by the numbers and techniques mentioned in the methods and results sections of published research papers. In order to critically evaluate research, you should be able to read more than just the introduction and conclusion sections of a paper. Quickly scanning for some significant p-value isn't enough. The patient population trusts you to be properly informed when you manage their health, so that's why we're here. You hear an emergency ward doctor directing her team while treating an accident victim. Okay, let's get on with the primary survey. It's a serious injury to his left leg. It's extremely pale, so blood flow could be an issue. But I'm worried about other serious injuries that aren't so obvious. A fracture of the pelvis, abdominal or spinal injuries. I think we better get the consultant emergency surgeon down here too. Okay, so you need to get the lines in, blood off, and we need to remove the rest of his clothing. We're going to want to get some x-rays done before anything else. Chest, pelvis, femur, please. And can somebody get a Doppler, please, so we can check his blood flow in the leg? You hear a doctor speaking to a woman who has presented with heart palpitations. And do you feel short of breath with the palpitations?
Yeah, and I'm losing my voice too.
So you'd just got to work and this happened?
Yeah.
When's the last time it happened?
A few months ago. I came here as well.
Okay, so I'm just going to try and massage the side of your neck here, just to see if that slows down your heart rate. Did they teach you how to try and hold your breath last time?
Yes, they did.
Did you try that this morning?
Yeah, I did.
Oh, great. Very good. Okay, well, that massage doesn't seem to be working. Let's try something else. What I want you to do now is to blow as hard as you can into this syringe. Ready? Blow, 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 blow. And stop. That doesn't seem to be doing much either. Alright, we need to drop that rate, so we better try some meds. You'll need a drip. You hear an emergency paramedic talking to an accident and emergency doctor about a patient who has fallen from his motorcycle. This gentleman's name is Brian. He came off his motorbike at a corner and his leg hit a telephone box.
Oh, I see. Looks like he fell pretty hard.
Yeah, when we arrived he was sitting up and talking, GCS 15 and no signs of head injury, just some pain in his right shoulder, but the main injury is a deformed and angulated right femur, which we've manipulated on the scene.
How's his circulation around the leg?
He had a cold avascular right foot at the time, and the blood supply seems to have come back post-manipulation. Numbers-wise, he's normal. He's had 150 milligrams of ketamine and a total of 8 milligrams of morphine as well.
Yeah.
Yes, 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 yes. My one is 18.
First part 7 from 12. Sorry? 6 by 12. And this
I got
right, wrong 2. 4 by 6.
my 5.
Yeah, okay. This is going more. Then symptoms present approximately 3 weeks. Patient suggests symptom related to age. Described pain as not severe, recurring condition. Treated for similar symptoms, number 5 times in last 10 years. Symptoms come and go. Patient forgets to drink water, nocturia, 3 times nightly. Pain urgency, 7, I didn't get it. Pressure, 9. Pressure greater at night. Antibiotics effective in the past. 8 also, I didn't get it. Okay, no urinary incontinence, no impact from coughing, sneezing, successful. Corvo suspension, ages 50. Known allergies, Sepertine. Okay. Then amoxicillin and trimethoprim, nitrofurantoin, short course nitrofurantoin, review appointment in 5 days.
Should I tell or she? Okay. Patient Mrs. Chambers, then presence after heavy bleeding, approximately 1 week, 36 weeks of pregnancy, previous episode at 28 weeks, last approximate 2 hours, estimated bleeding half cup, current episode 3 hours, ongoing spotting and passing clots, estimated bleed 1 cup, tightness and cramps, severe pain in lower abdomen, concurred with bleeding, symptom comes and go like period pain, pregnancy normal to date, previous scan found previous scans found 6 placenta low, no further scan scheduled. 12 weeks scan showed baby was small but fine, antenatal clinic visit normal, low Downs risk, number of previous pregnancies twin, number of previous pregnancy 1, and boys twins healthy normal delivery. 4 years ago abdominal myomectomy, suffered from migraines, body aches, fever, emergency MRI found large fibroid. Okay. Okay, good.